Welcome to the deep dive. Today we're tackling something that really blends intricate mechanics with some quite complex decision making. It's the kind of puzzle I think that resonates whether you're building a product, managing a team, or, well, in this case, dealing with a broken bone.
Mhm.
We're diving into proximal humerus fractures, often just called a broken shoulder.
Indeed. And it's an injury that really highlights how something seemingly straightforward, like a simple fall, can actually lead to surprisingly complex challenges.
Right.
So for this deep dive, we've looked at a range of expert sources, insights from the Orthopedic Trauma Association, detailed clinical reviews like stat pearls and orthobullets, bits from the Bone School, and also a summary document from the Stanford AVA lab.
Okay. And our mission today is really to distill the essential knowledge from all of that material. Why focus on this specific injury?
Well, partly because it's remarkably common, isn't it? Particularly among older adults.
Yes, very much so. And managing it really seems to involve navigating complexity, evaluating trade-offs, often under uncertainty, and committing to what sounds like quite a demanding recovery. These feel like universal themes.
Absolutely. By looking closely at the sort of anatomy of the problem, how we classify its severity, the nuanced choices around treatment, and the realities of recovery and managing potential risks in a specialist field like orthopedics, we definitely find parallels.
Mm-hmm.
Parallels to strategic challenges you might face in, well, any professional field, really. It's about understanding a specific intricate system to gain perhaps broader insights into problem solving and resilience.
Right. Okay. Let's get into the mechanics of it then. When we talk about a proximal humerus fracture, where exactly are we focusing? What's the actual system we need to understand here?
Okay, let's start with the basic structure, drawing on the descriptions in sources like the OTA and stat pearls. Your shoulder joint is, well, it's a marvel of mobility, really.
Yeah.
And at its core, you have three bones. The clavicle, your collarbone, the scapula, which is the shoulder blade, and the humerus, your upper arm bone.
Okay.
The proximal humerus is simply the section of that humerus closest to the shoulder joint. So essentially, the very top of the arm bone.
So the part that forms the ball in the ball and socket joint of the shoulder.
Precisely. But this ball region, it's not just one simple solid structure. To really understand how it breaks, orthopedically, it's often viewed as being made up of four functional parts.
Four parts.
Yes.
Mm.
This way of thinking was really crystallized by the surgeon Charles Neer, whose classification system we'll definitely come back to.
Okay.
These parts are based on how the bone tends to fragment when it's injured, often along weaker lines or areas where key tendons attach.
Four parts within just the top of that one bone. That already sounds more complex than just a simple break. What are they?
Well, based on the detailed descriptions across our sources, stat pearls, orthobullets, they all cover this. These four key parts are, firstly, the articular segment. That's the rounded, smooth, cartilage-covered surface of the humeral head itself.
Right.
The actual ball part that moves against the socket on the shoulder blade.
It's a surface that allows that smooth movement.
Exactly. Then, just below that articular surface, you have the anatomic neck.
Anatomic neck. Okay.
This is basically the line where the original growth plate was in childhood, separating the head from the rest of the bone. Fractures right along this line can be tricky because they're very close to the blood supply feeding the humeral head itself.
Right. That sounds important. Okay. Anatomic neck. What's the third part?
The third is the surgical neck. This is located a bit further down the bone, below those bony bones called the tuberosities. We'll get to those next.
Okay.
It's often described as the narrowest point or perhaps the weakest structural zone of the upper humerus. And this is a critically important area because a very high percentage of proximal humerus fractures happen right here, through the surgical neck, especially in things like falls onto an outstretched arm. It's just a frequent point of failure under stress.
That makes sense. A point of sort of mechanical vulnerability. Okay, so we have the articular surface, the anatomic neck, the surgical neck. What's the fourth part?
The fourth part, well, it actually refers to two bony prominences or bumps located just below the humeral head on the side of the bone. These are the greater tuberosity and the lesser tuberosity.
Right.
The greater tuberosity is on the outer side of the shoulder, and it's the crucial attachment point for three of the four rotator cuff muscles, the supraspinatus, infraspinatus, and teres minor. These muscles are absolutely vital for lifting and rotating the arm outwards.
Okay.
The lesser tuberosity is on the front of the bone, and that's where the subscapularis muscle attaches, which helps with inward rotation.
So these tuberosities aren't just bumps then. They're actually anchors for the muscles that power our shoulder movement.
Precisely. They are completely integral to the function and the stability of the joint. And actually, The groove that runs between these two tuberosities, that's called the bicipital groove. That's where the long head of the biceps tendon runs.
Okay.
So when we talk about a proximal humerus fracture, we're talking about a break that affects one or more of these four functional units: the head, the anatomic neck, the surgical neck, or those tuberosities.
And the nature of the fracture, it depends on which of these parts break and, crucially, how they move relative to each other.
Absolutely. That's the crux of it. The OTA source really highlights that the pattern and the severity are highly variable. It depends heavily on which parts are fractured, and really importantly, the extent to which these fractured segments have moved, or, as we say, displaced from their normal anatomical position.
Right.
This displacement is absolutely key to determining the stability of the fracture and ultimately how it should be treated.
That leads us neatly into how these injuries actually happen. You mentioned it's not just one type of event. The sources point to quite a distinct pattern, don't they?
They do, yes. Stat pearls and orthobullets both really emphasize what's called the classical bimodal distribution of these fractures.
Bimodal, meaning?
It means the injury mechanism and the type of patient affected tend to fall into two pretty distinct peaks, or groups. Understanding these patterns helps us understand the underlying risk factors and often the likely bone quality involved.
Okay, let's explore these two groups. What's the most common scenario then?
Well, the largest group, and this accounts for the clear majority of these fractures, involves older adults, typically people over the age of 65.
Okay.
In this demographic, the injury is usually caused by a low-energy mechanism. Most commonly, it's a simple fall from standing height. The classic scenario is someone tripping, falling onto an outstretched hand, or perhaps directly onto their elbow or shoulder.
And this is where bone density comes into play, I assume.
Exactly. Stat Pearls explicitly notes that in this older population, these fractures are very frequently fragility fractures.
Fragility fractures,
Right.
meaning the bone breaks easily.
Precisely. It means the bone has broken not necessarily because the force was immense, but because the bone quality itself has been compromised, usually by osteoporosis or osteopenia, thinning of the bone.
Right.
The bone simply isn't strong enough to withstand even a moderate force. And these fragility fractures are a really significant contributor to the overall healthcare burden associated with osteoporosis.
I see.
The incidence of proximal humerus fractures is cited as high as maybe 4% to 6% of all adult fractures. And notably, there's a strong female predominance, a reported 2.1 female-to-male ratio, which reflects the higher prevalence of osteoporosis in women.
So a very common issue in older women, often acting as a sort of red flag for underlying bone weakness. What about the other group in this bimodal distribution?
The second peak involves younger, typically more active patients. Now, for them, it takes a much higher energy trauma to cause a fracture in the proximal humerus because their bone is generally much stronger and denser. Examples of these high-energy mechanisms would be things like road traffic collisions, falls from significant height, or maybe high-impact sports injuries. That's described in the OTA and stat pearl sources.
Right.
These injuries in younger patients are often more severe. They might involve more comminution, that means shattering of the bone, and they carry a higher risk of associated injuries to the surrounding soft tissues, nerves, or blood vessels, just because of the sheer force involved.
It's a stark contrast, isn't it? A simple stumble for one group versus a major impact for the other really highlights different underlying vulnerabilities or the external forces at play. So, someone sustains this injury. What are the immediate signs and symptoms you'd expect to see?
Well, the clinical presentation is usually quite dramatic and pretty typical of a significant bone injury near a major joint. Severe pain is almost always the primary symptom, localized right around the shoulder and the upper arm. And this pain is significantly worse with any attempt at all to move the arm. Swelling and bruising are also very common.
Right.
And because of gravity, the bruising can actually be quite extensive. It might track downwards over several days, sometimes appearing around the elbow, or even further down in the forearm or hand. That's mentioned in the OTA and unknown 19 sources.
Wow.
Patients will typically hold the injured arm very close to their body, often supporting it with the other hand, and report an inability or just extreme reluctance to move it actively. Sometimes they might describe a grating or grinding sensation, we call that crepitus, if the fractured bone ends are unstable and rubbing together.
And beyond just observing and asking about the pain, a physical examination sounds absolutely crucial to assess the full extent of the damage.
Oh, absolutely critical. A thorough physical examination is indispensable. The clinician will visually inspect the shoulder, looking for any obvious deformity, swelling, or that bruising we mentioned.
Mm-hmm.
They'll gently palpate the area, feel around to identify points of maximal tenderness, and potentially feel for that crepitus. However, a vital component of the examination, and this is heavily emphasized in stat pearls and orthobullets, is the neurovascular assessment.
Neurovascular,
Mm.
checking nerves and blood vessels.
Exactly. Checking the function of the nerves and the blood vessels supplying the arm and hand.
Why is that specific check so important in a shoulder fracture compared to, say, a broken wrist?
It's because of the very close proximity of major nerves and blood vessels to the proximal humerus, particularly around that surgical neck area where so many fractures occur.
Ah,
The nerve most frequently at risk in these injuries is the axillary nerve. This nerve actually wraps around the surgical neck of the humerus,
right.
and it supplies motor function to the deltoid muscle, that's the big muscle covering the shoulder, essential for lifting the arm away from the body. It also supplies sensation to the skin over the outer aspect of the shoulder, sometimes called the regimental badge area.
So damage to that nerve could mean real weakness in lifting the arm.
Precisely. A complete axillary nerve injury can result in a noticeable weakness or even inability to abduct to lift the arm sideways, and often a patch of numbness on that outer shoulder.
Right.
Orthobullets notes that axillary nerve palsy, or weakness, can occur in quite a significant percentage of cases, potentially up to 58%, based on some EMG studies, although many of these might be temporary or partial injuries, what we call neuropraxia.
Okay.
It's also highlighted that the nerve is particularly vulnerable during certain surgical approaches, for instance, with lateral pin placement, if doing percutaneous fixation.
Are blood vessels also at risk then?
Yes, though perhaps less commonly injured than the axillary nerve, especially in lower energy fractures. The axillary artery runs close by and can potentially be damaged, particularly in severely displaced fractures or fracture dislocations, or in those high-energy traumas.
Mm-hmm.
Scott Pearls mentions arterial injury occurs in perhaps up to 5% of cases, so it's absolutely crucial to check the patient's pulses in the wrist and hand and assess the color and temperature of the limb to make sure there's adequate blood flow. Although, as Orthobullets points out, the shoulder has quite good collateral circulation alternative blood pathways. So relying solely on pulses might sometimes miss a more subtle vascular issue. Assessing motor function and sensation for other major nerves like the radial and musculocutaneous nerves is also part of a thorough exam.
So pain, bruising, swelling, potential nerve, or even vascular compromise, it sounds quite involved. How do clinicians then get a really precise blueprint of the fracture pattern itself to guide their decisions?
Yeah, that's where medical imaging becomes absolutely indispensable. Radiographs, or X-rays as most people know them, are the absolute cornerstone. They're the mandatory initial step.
Right.
And our sources are very specific about the views required to get a complete picture. You need what's called a complete trauma series of the shoulder. This isn't just one or two quick pictures.
A trauma series, what does that typically include?
Well, it involves several views taken at different angles. The aim is to get orthogonal, meaning 90-degree perspectives, which are essential for judging displacement in multiple planes. You need to see it front on and side on, essentially.
Okay.
Q views usually include, first, a true AP anteroposterior view, sometimes called a Grashy view. This is taken with the patient rotated slightly, so the X-ray beam goes straight through the glenohumeral joint space, showing it clearly without the scapula overlapping. Gives you that front-on view of the joint.
Right.
Second, a scapular Y view. This is a lateral or side-on view. It's taken with the patient positioned, so the scapula is seen on its side, and it looks a bit like the letter Y. The humerus should normally sit right in the center of that Y.
Okay.
This view is excellent for assessing if the humeral head has shifted forwards or backwards relative to the socket, and it also helps rule out shoulder dislocations.
And a third view.
Yes, usually an axillary lateral view.
Yeah.
This one is taken ideally with the arm abducted, lifted slightly away from the body, if the patient can manage it, shooting the X-ray beam up from the armpit area.
Ah, okay.
This view is crucial for assessing displacement in the axial plane. So, again, forward or backward movement, and for seeing those tuberosities clearly in profile. Now, if the patient can't lift their arm due to pain or the injury itself, modified axial views or other techniques might be needed.
That makes sense, getting multiple angles to see the problem from all sides, like looking at a complex structure from different viewpoints before you decide how to fix it. What if those standard X-rays aren't quite enough, if it looks particularly complicated?
Exactly. If the fracture pattern is very complex, maybe shattered into many pieces, or if there's a strong suspicion that the break extends right into the joint surface itself, what we call intra-articular involvement, or simply if you need more detail for surgical planning, then a CT scan, computed tomography, is incredibly valuable.
Right.
Stat pearls and orthobullets both highlight its utility. A CT scan provides detailed cross-sectional images, almost like slices through the bone. It allows surgeons to see precisely the number and position of all the fragments, the degree of comminution, how shattered it is, and the exact relationship of the humeral head to the glenoid socket.
Mm-hmm.
This is vital for planning how to fix it, whether with pins, plates, or even a replacement. It's particularly good for assessing the position of those tuberosities and the state of the articular surface.
An MRI, is that ever necessary for these fracture?
MRI, magnetic resonance imaging, is less commonly used for assessing the bone fracture itself. Its strength is really in evaluating soft tissues. As orthobullets points out, an MRI might be considered if there's a strong suspicion of a significant associated soft tissue injury that could really impact the treatment or the outcome. For example, a complete tear of the rotator cuff tendons, or perhaps significant ligament damage, which might happen alongside the fracture in those higher energy traumas.
Okay, so imaging gives us that detailed blueprint. Then comes the task of actually classifying the damage, which seems to be where orthopedic surgeons translate all this complex image data into a framework for making decisions. We mentioned the near classification earlier. Let's dig into that. How does it work, and why is this active classification so central to deciding the path forward?
Yeah, classification is absolutely fundamental in orthopedic trauma. It does two main things. It provides a common language so surgeons can communicate effectively about specific injury patterns, and it provides a framework for grouping similar injuries together,
Right.
which in turn helps guide treatment algorithms and allows us to compare outcomes in research studies. The near classification, which is based on those four functional parts we discussed earlier, the articular surface or head, the greater tuberosity, the lesser tuberosity, and the shaft or surgical neck region, is arguably the most widely used system for proximal humerus fractures.
Okay.
And it classifies fractures based purely on the number of these four primary parts that are significantly displaced.
So it's not just about how many fracture lines you can see on the X-ray, but specifically about how far the main pieces have moved. That feels like a key distinction.
It is the key distinction. That's the critical insight from Neer's system. A fracture line can exist, maybe multiple lines, but if the pieces remain in relatively good alignment, it's treated very differently than if they've shifted significantly out of place.
Okay.
According to stat pearls and orthobullets, a segment is considered significantly displaced if it is moved by more than 1 centimeter, or 10 millimeters,
Like,
or if it's angled by more than 45 degrees relative to its normal anatomical position.
right.
Those are the specific thresholds used to determine if a part counts towards the classification number.
Got it. Okay, so let's walk through the near categories based on that displacement rule. How does it start?
Right. It starts simply, a one-part fracture. This means there are fracture lines present in the proximal humerus, potentially separating multiple segments, but, and this is the crucial bit, none of the four main parts, head, tuberosities, shaft, are displaced by more than that 1 centimeter or 45 degrees.
Got it.
So it's key. Multiple cracks don't automatically make it a multi-part fracture in the Neer system if the fragments are still essentially in place. Orthobullets notes that these minimally displaced fractures, often technically two-part surgical neck fractures but with minimal shift, are actually the most common type we see.
So even if there are breaks technically separating several areas, if everything stays relatively put, it's classified as a one-part. That's maybe a bit counterintuitive at first. What's a two-part fracture then?
A two-part fracture means there are fracture lines separating two or more segments, but only one of those four major functional parts is significantly displaced again, more than 1 centimeter or 45 degrees.
Just one part moved significantly.
Yes. A very common example highlighted by orthobullets is a surgical neck fracture, where the main shaft fragment is displaced upwards or angled, but the humeral head and the tuberosities remain together as a single unit and in reasonable alignment relative to each other. Or, alternatively, maybe the greater tuberosity alone is pulled off and displaced, but the head and shaft remain aligned.
Okay, makes sense. And it just increases from there.
Exactly. A three-part fracture involves fracture lines separating 3 or more segments, and now 2 of the 4 primary parts are significantly displaced relative to the others.
2 parts out of place.
Yes. So a typical 3-part fracture might involve a fracture through the surgical neck with significant displacement of both the greater and lesser tuberosities relative to the humeral head and shaft, or perhaps displacement of just one tuberosity in the surgical neck fragment, The point is, two of those four core units are significantly out of alignment.
Right. And finally, the most severe in this system.
That would be the four-part fracture. This is the most complex and generally unstable pattern classified by Neer. It means there are fracture lines separating all four primary parts, the articular segment head, the greater tuberosity, the lesser tuberosity, and the shaft. And three of these four parts are significantly displaced relative to each other and the remaining segment.
Wow.
The blood supply to the humeral head is often significantly compromised in these injuries, which dramatically increases the risk of the bone in the head dying off, what we call a vascular necrosis, or AVN. Okay. Orthobullets also mentions some specific patterns that are particularly problematic, like fractures right through the anatomic neck, which have a very high risk of AVN, fracture dislocations, where the humeral head is not only broken but also completely out of the socket, and head split fractures, where the articular surface itself is actually shattered. These are often considered within or alongside the four-part category due to their severity and implications for treatment, especially the risk to blood supply.
So the Neer system provides a kind of shorthand, driven entirely by displacement, for communicating the complexity and the likely instability of the fracture. We also saw mention of another system, the AOTA classification. Is that widely used as well, or is it more for specific purposes?
Yes, the AOATA system is another important classification, and it's also referenced in stat pearls and orthobullets.
Yeah.
It's generally a more detailed and comprehensive system than Neer. It's actually part of a much larger universal system designed for classifying all bone fractures throughout the body.
Oh, okay.
It organizes proximal humerus fractures into three main groups labeled A, B, and C, based primarily on whether the fracture is extra-articular, meaning it doesn't involve the joint surface directly, those are the A types, partially intra-articular, some involvement of the joint surface, the B types, or fully intra-articular, crossing the joint surface significantly, the C types.
Right.
And then within each of those groups, there are numerous subgroups that detail specific fracture patterns and the level of comminution, or shattering. Unknown 19 mentions that a newer version from 2018 attempts to integrate some of Neer's concepts about displacement while providing even greater descriptive power.
So more detailed.
Yes, much more granular.
Yeah.
It's often preferred in research settings because it allows for very precise comparisons between studies. And it's also very useful for detailed preoperative planning, especially for the really complex cases, as it allows for finer distinctions in the fracture patterns. But perhaps for day-to-day communication, Neer is still very commonly used because of its relative simplicity based on that key concept of displacement.
Okay, so we've sort of dissected the anatomy, understood the ways it breaks, and how those breaks are classified based on displacement. Now comes the really crucial, and it sounds like often challenging phase, deciding on the actual treatment. This seems less like a simple A or B choice and much more like navigating a complex decision tree, especially given all the variability in patients and fracture patterns.
It is indeed a complex decision. This is where applying all that knowledge to a very specific situation becomes paramount, much like, as you say, strategic decision-making in other fields. And here's where it gets really interesting and perhaps quite counterintuitive for many people.
Okay.
The sources we looked at consistently state that the majority of proximal humerus fractures are actually treated successfully without surgery.
Really?
Yeah.
That is surprising. When you picture a broken shoulder, I think most people instinctively assume surgery is needed.
It's a common assumption, but the data suggests otherwise. Both the OTA and StatPearl cite figures suggesting that somewhere between 80% and 85% of these fractures can be managed non-operatively.
80 to 85%.
Well,
Wow. So non-operative management is the default path for most.
for fractures that are minimally displaced, and remembering what minimally displaced means in the Nair system, no part displaced more than 1 centimeter or 45 degrees non-operative management is generally the preferred approach.
Okay.
This includes almost all one-part fractures, even if there are multiple fracture lines visible, and indeed many two-part surgical neck fractures, where the displacement is still within those accepted limits. Even some displaced greater tuberosity fractures might be managed non-operatively initially, although orthobullet specifies that displacement of the greater tuberosity by more than about 5 millimeters is usually considered unacceptable for non-operative treatment.
Why is that specific tuberosity displacement such an issue?
Because the rotator cuff muscle is attached there. If that fragment heals in a position that's too high or too far back, it can physically block the shoulder from moving properly, causing painful impingement and significant loss of function, especially lifting the arm. The muscles pull it out of place.
Right, makes sense. So if the pieces are still in relatively good alignment, the body is often capable of healing it itself given the chance.
Precisely. The goal of non-operative treatment is simply to allow the bone to heal naturally in an acceptable position, while trying to maintain as much shoulder function as possible throughout the process. It's essentially a trust in the body's own biology.
Okay.
This management typically starts with a period of immobilization, usually just for a few weeks, maybe 2 to 3, in a sling or a similar support like a shoulder immobilizer. This is primarily for comfort during the initial, very painful phase, and also to provide some protection for the healing tissues.
Just a few weeks of immobilization, not months of being completely still then.
Crucially, no, and this is a really key point highlighted across the sources. Prolonged, rigid immobilization of the shoulder is actually detrimental
Why is that?
because it inevitably leads to significant stiffness. The shoulder capsule thickens and contracts, potentially resulting in a frozen shoulder or adhesive capsulitis, which can be incredibly difficult to recover from.
Ah, right.
So the non-operative protocol needs to transition relatively quickly into a phase of progressive, supervised physical therapy and rehabilitation. As early as, say, 10 to 14 days after the injury, once the very acute pain starts to settle, patients are often encouraged to begin gentle range of motion exercises, such as pendulum exercises, as their pain allows.
Pendulum exercises, that's just letting the arm hang down and gently swinging it.
Exactly. Using gravity to create some gentle movement at the shoulder joint without actively using the muscles. This helps prevent the capsule from seizing up.
Okay.
Then, active assisted range of motion where the patient uses their good hand, or a therapist helps, to move the injured arm typically begins around 4 to 6 weeks once the initial pain has subsided further and there's some early biological healing starting. Full active range of motion using their own muscles and then strengthening exercises follow on from that, gradually increasing in intensity as the bone continues to heal and symptoms improve. It requires significant patient buy-in, though. Diligence is key. And a good rehabilitation team is vital, as noted in Unknown 19. Pain management throughout this whole process is also absolutely critical to allow participation in therapy.
How long does the bone itself take to heal?
The bone itself usually takes roughly 3 to 4 months to achieve solid biological healing, or union, according to the OTA. But, and this is important, regaining full function, the movement and strength, often takes considerably longer.
Okay, so non-operative is the main path for most, focusing heavily on early movement and diligent rehab. When is surgery indicated then? When do clinicians decide that the risks and costs of operating are actually outweighed by the potential benefits?
Surgery is generally reserved for those fractures that are significantly displaced beyond those near thresholds, or fractures that are inherently unstable, or ones that involve specific patterns that are considered unlikely to heal well or restore adequate function if they're just left in the sling.
Right.
The decision is also very heavily influenced by patient factors. We have to consider their age, their overall health, their functional demands. What do they need to be able to do with that arm? Their general activity level, the quality of their bone, is it strong or osteoporotic, and even things like their hand dominance.
Okay.
For example, a young, active person with a significantly displaced 3-part fracture is much more likely to benefit from surgery aimed at restoring the anatomy as perfectly as possible to give them the best chance of optimal long-term function. That might be different compared to, say, an older, less active individual with lower functional demands and perhaps poorer bone quality, where the risks of surgery might be higher and the potential gains less critical for their lifestyle.
Makes sense.
Stat Pearls and OrthoBullets outline several main surgical options, each with its own specific indications, advantages, and potential drawbacks.
Okay, let's try and walk through the main surgical strategies then. It sounds like there are different approaches for different types of break or maybe different types of patient.
Exactly. It's all about tailoring the solution to the specific problem and also to the capabilities of the system, meaning the patient's bone quality, their overall health, their ability to participate in rehab, and so on. One option is closed reduction and percutaneous pinning, CRPP.
Closed reduction, meaning no big cut.
That's right. It involves manipulating the bone fragments back into a better alignment without making a large surgical incision, closed reduction, and then holding them in that position using metal pins or sometimes wires, which are inserted through small poke holes in the skin, percutaneous pinning.
Okay. When would that be used?
It's often considered for certain 2-parter or maybe some 3-part surgical neck fractures, or occasionally specific 4-part fractures, particularly in patients who have good quality bone, where the fragments can be manipulated back into place relatively easily and are expected to hold with just pins.
What are the sort of pros and cons of that approach?
Well, the main advantage is that it's less invasive than open surgery. That potentially means a quicker initial recovery, less disruption to the blood supply.
Right.
But the fixation isn't as mechanically strong or rigid as using plates and screws.
Right.
Orthobullets notes that CRPP can have higher rates of certain complications, like pin site infections or loss of reduction, meaning the bone slipping out of place again after surgery compared to other methods. And as we discussed earlier, the axillary nerve is definitely at risk, particularly with pins placed from the lateral or outer side.
Okay. What about using plates and screws? That sounds like a much more rigid way to hold everything together.
It is. That's open reduction and internal fixation, or IF. This is a more direct approach. It involves making a surgical incision, exposing the fracture site, open reduction, carefully putting the bone fragments back together like a jigsaw puzzle under direct vision, and then fixing them firmly in place using anatomically pre-contoured metal plates and screws.
Okay.
This is often indicated for displaced 2, 3, and particularly some 4-part fractures, especially those displaced surgical neck fractures and significantly displaced tuberosity fractures. Remember those needing to be pulled back down if displaced more than 5 millimeter. It's often the preferred method in younger patients where restoring the precise anatomy is considered critical for optimal long-term function. Unknown 19 mentions it's typically aimed at younger patients, or those where the fragments are distinct and manageable enough to piece back together.
Are there specific technical challenges with using plates and screws in this particular bone, the humerus?
Yes, absolutely. Especially given that many of these fractures, the low-energy ones, occur in older patients who often have osteoporotic bone.
Meaning the bone is soft?
It's exactly soft and sometimes quite brittle, which doesn't provide a very strong grip for the screws. Orthobullets goes into significant detail on this. A key challenge is providing adequate support on the inner or medial side of the humerus.
Why is that side so important?
Because without good support there, the humeral head has a tendency to collapse or shift downwards and inwards into what we call a varus position, especially if the bone is shattered underneath, commented. This varus collapse is a common failure mechanism.
Right.
So surgeons use specific techniques to try and prevent this. They might place a specific screw, called a calcar screw, upwards into a denser area of bone on that medial side. Or sometimes, particularly in severe comminution, they might even use a piece of donor bone, often a strut graft taken from the patient's fibula, lower leg bone, and place it alongside the plate to act as a buttress, providing that crucial medial support.
Wow, using bone from the leg.
Yes, it can provide excellent mechanical support. Even with these techniques, screw cutout, where the screws lose their grip in the soft bone of the humeral head and pull out, remains a significant and relatively common complication after locking plate fixation. It's reported in maybe up to 14% of cases in some series. Careful plate positioning is also essential to avoid irritating or damaging nearby structures, like the rotator cuff tendons or blood vessels.
It really sounds like a technically demanding surgery, particularly when dealing with weaker bone. What about the option of using a rod inside the bone instead?
Yes, that's intramedullary nailing, IMN. This involves inserting a specially designed metal rod down the hollow central canal, the medullary cavity of the humerus. This rod crosses the fracture site. Screws are then inserted through the bone and into the nail, both above and below the fracture, to lock the fragments in the nail together and control rotation.
Okay. When is nailing used?
It's typically used for certain fractures of the surgical neck, or perhaps some specific 2- or 3-part fractures. It's often considered in younger patients with good bone quality, or sometimes when there's also a fracture further down the humeral shaft that needs fixing as well, the nail can potentially address both.
What are the pros and cons of nailing compared to, say, pleating?
Well, orthobullets suggest IMN can potentially have favorable healing rates and might allow for slightly earlier range of motion compared to plates in some cases, as it acts more like an internal splint, a load-sharing device. However, a potential downside is the insertion point for the nail.
Where does it go in?
It usually has to be inserted through the very top of the humerus, which often requires making a split in or going through part of the rotator cuff tendons, usually the supraspinatus. This necessary violation of the rotator cuff can sometimes lead to persistent shoulder pain or impingement symptoms after surgery. There are also risks to nerves, particularly the axillary and radial nerves, with the placement of the locking screws used to secure the nail.
Okay, so different trade-offs again. Now, what about the most significant intervention, replacing the joint entirely?
Right, that's arthroplasty, or shoulder replacement. This is generally considered for the most severe fracture patterns where the bone fragments are deemed unlikely to heal reliably, perhaps where the articular surface itself is badly damaged or split, or, crucially, where the blood supply to the humeral head is thought to be significantly compromised, leading to a very high risk of that avascular necrosis, AVN, the bone dying off.
Hmm.
It's also sometimes used as a salvage procedure if other surgical attempts, like ORIF, have failed. Arthroplasty is generally chosen more frequently for older patients, especially those with poorer bone quality, or perhaps those who already had significant shoulder arthritis or rotator cuff problems even before the fracture. The sources describe two main types used for fracture.
Okay, what are they?
The first is hemiarthroplasty. Hemi meaning half. This involves replacing only the humeral side of the joint. The ball is replaced with a metal prosthesis. The socket side, the glenoid on the shoulder blade, is left as it is. This might be used in slightly younger patients, maybe those aged 40 to 65, with certain fracture patterns where the head isn't salvageable but the rotator cuff is still functional. Or it's also an option in older patients with severely shattered anatomic neck fractures or four-part fractures, as described in stat pearls and orthobullets.
What's the main challenge with hemiarthroplasty for fractures?
A really critical challenge is getting those tuberosity fragments, remember, where the rotator cuff muscles attach to heal correctly onto the metal prosthesis and in the right position. This is technically demanding. If the tuberosities don't heal properly or heal in the wrong place, then the rotator cuff function is compromised, which can significantly limit movement, particularly the ability to rotate the arm outwards.
Okay. And the other type of replacement, the one that sounds like it's becoming more common?
Yes, that's the reverse total shoulder arthroplasty, RSA. This is being used increasingly, particularly in older, perhaps less functionally demanding patients with complex fractures. It's called reverse because it fundamentally alters the shoulder's normal biomechanics.
Oh, so.
In a standard shoulder replacement, you replace the ball with a metal ball and the socket with a plastic socket. In an RSA, you actually put the ball component onto the shoulder blade side on the glenoid socket, and you put a socket component onto the top of the humeral bone.
It flips the joint around?
Exactly. It
Yeah.
effectively reverses the ball and socket. The clever thing about this design is that it allows the large deltoid muscle on the outside of the shoulder to become the primary elevator of the arm, effectively bypassing the need for a functional rotator cuff.
Ah, I see.
So it's indicated in elderly patients with very complex fractures, especially four-part fractures, those where the tuberosities are shattered beyond repair, non-reconstructible, those with very poor bone stock making fixation difficult, or importantly, those who already had large irreparable rotator cuff tears before they even broke their shoulder.
So the RSA is chosen when the normal engine for lifting the arm, the rotator cuff, is damaged or can't be relied upon, and it essentially leverages a different engine, the deltoid muscle, to do the work.
That's a very good way to think about it, yes. It shifts the joint's center of rotation downwards and inwards, which tensions the deltoid muscle fibers more effectively, allowing them to lift the arm even without a working rotator cuff.
Interesting.
Orthobullets notes that even when doing an RSA for fracture, attempting to repair the greater tuberosity fragment back to the prosthesis is still generally recommended if possible, as it seems to improve the overall range of motion, particularly rotation.
Okay.
And stat pearls adds an interesting observation. RSA performed as a primary procedure for a bad fracture, or perhaps after failed non-operative management, might actually yield better functional outcomes than RSA performed as a salvage procedure after a failed attempt at ORIF with plates and screws.
Why might that be?
The thinking is perhaps there's less scarring and damage to the surrounding muscles and tissues in the non-operative group compared to those who've had a previous complex open surgery that didn't succeed.
It's really clear there's no single best treatment then. It's all about carefully matching the intervention to the specific patient, the specific fracture pattern, and the predicted likelihood of success with the different methods, considering all those risks and benefits. Which brings us to the journey after the initial treatment, the road to recovery. This sounds like it's probably a marathon, not a sprint.
Absolutely. That's a very apt description. Whether treated non-operatively with just a sling or operatively with complex metalwork, recovery from a proximal humerus fracture is often a lengthy and demanding process for the patient.
Right.
While the bone itself might achieve biological union, as we said, in maybe 3 to 4 months, according to the OTA, regaining full or even near full pain-free range of motion, strength, and functional independence takes significantly longer, often 6 months to a year and sometimes even more.
That's a really substantial commitment of time and effort. What makes the recovery so particularly challenging with this injury?
Well, several factors contribute. Pain is often prolonged, especially in the early stages, and managing it effectively is key to enabling rehabilitation. Stiffness is a major, major hurdle.
Stiffness?
Yes, the shoulder joint is notoriously prone to developing adhesive capsulitis, that frozen shoulder, after almost any significant injury or period of immobilization. And this can happen regardless of whether it was treated non-operatively or operatively.
Okay.
Regaining strength in the shoulder and arm muscles, which weaken very rapidly with disuse, requires dedicated, consistent effort over many months. And Unknown 19 also highlights something important: the significant emotional and psychological impact these injuries can have.
How so?
Well, think about the loss of independence, the inability to perform simple daily tasks like dressing or cooking, the persistent pain, and sometimes the frustratingly slow pace of recovery. This can understandably lead to frustration, anxiety, and sometimes even depression, which in turn can impact motivation for rehab.
So that diligent physical therapy we talked about earlier isn't just recommended, it sounds absolutely essential.
It is absolutely non-negotiable. You simply won't get the best possible outcome without it. A structured, progressive rehabilitation program, guided by a physiotherapist, is the cornerstone of recovery, whether the fracture was treated with a sling or with the most complex surgery.
Right.
OrthoBullets describes a typical multi-phase program, starting with those gentle, often passive or pendulum, range of motion exercises very early on, progressing carefully to active assisted and then full active range of motion as healing allows and pain settles, and finally, incorporating progressive strengthening exercises for the rotator cuff, deltoid, and scapular stabilizing muscles, along with more advanced functional exercises relevant to the patient's goals. Without this commitment to physical therapy, significant stiffness and lasting limitations in movement are almost guaranteed. This is stressed across all the main sources: the OTA, OrthoBullets, Unknown 19.
What are the potential long-term outcomes then, even assuming successful treatment and good rehab? Are there often lingering issues people should be aware of?
While most patients will certainly see significant improvement over time, it is important to manage expectations realistically. Full restoration back to exactly the pre-injury level of function isn't always achieved, particularly with the more complex fracture patterns, or often in older patients.
Okay.
The OTA mentions that persistent stiffness, perhaps not regaining the last few degrees of motion, some degree of ongoing soreness or pain, particularly with certain activities or weather changes, and maybe not quite regaining the original level of strength. These are not uncommon long-term outcomes. The shoulder might just feel and move a bit differently than it did before the injury, even years later.
And beyond just those lingering symptoms, what about actual complications that can arise, either during healing or later on? We touched on some earlier, like nerve injury or infection.
Yes, unfortunately, complications can occur with both non-operative and operative management, and they can obviously significantly impact the final outcome, sometimes requiring further intervention. Drawing from the information in Stat Pearls, OrthoBullets, and Unknown 19, the potential complications include quite a range. Non-union. This is where the bone simply fails to heal completely. OrthoBullets states this is perhaps most common after two-part surgical neck fractures, and risk factors include being older, being a smoker, and significant displacement initially.
Right.
Malunion. This means the bone does heal, but it heals in a poor or abnormal position, maybe with significant angulation or displacement remaining. A malunited greater tuberosity fragment, for instance, healing too high, is a classic cause of chronic pain and impingement of the rotator cuff tendons when lifting the arm.
Ah, okay.
A vascular necrosis, AVN. I mentioned this. The blood supply to the humeral head gets disrupted by the fracture lines, causing the bone tissue in the head to die. This can lead to the head collapsing or fragmenting over time, causing pain and arthritis. It's a significant risk, particularly in those four-part fractures and anatomic neck fractures, precisely because the fracture lines run through areas critical for blood supply. Stiffness adhesive capsulitis, that frozen shoulder we discussed.
Right.
A significant loss of range of motion due to scarring and thickening of the joint capsule. This is a risk in almost any significant shoulder injury or surgery, but particularly common after fractures due to the initial trauma and necessary periods of immobilization.
Okay.
Nerve injury. While some nerve issues might be present right from the initial injury, nerve damage can also occur during surgery, or sometimes nerve function doesn't recover fully. The axillary nerve is the most commonly affected. Radial and musculocutaneous nerve injuries are less common, but certainly possible.
Right.
Hardware complications. These are specific to operative treatment involving plates, screws, pins, or nails. Examples include that screw cut out from the bone, especially with plates in poor quality osteoporotic bone. Hardware can also loosen over time, break, or sometimes just become prominent or irritating, requiring removal later on.
Mm,
Infection. Always a risk with any surgery, though thankfully relatively low with modern techniques. It can be devastating if it occurs, often requiring further operations.
yeah.
Post-traumatic arthritis. Arthritis can develop in the shoulder joint over time, sometimes years later, especially if the original fracture involved the articular surface, or if there was Malunion or AVN that altered the joint mechanics.
Okay.
And these complications, particularly things like painful non-union, Malunion, AVN, or severe stiffness, can sometimes necessitate further surgery down the line. Often, this might involve converting to a salvage shoulder replacement, particularly in older individuals, if the pain and dysfunction are severe enough.
It really highlights that fixing the initial break is just the very beginning, isn't it? Managing the whole biological and mechanical environment to get successful healing and good long-term function is incredibly complex. It also underscores the need for expertise right at the start in diagnosis. What else could potentially cause similar symptoms that might be mistaken for a proximal humerus fracture initially?
That's a critical point for clinicians. Yes, being able to distinguish a fracture from other potential sources of severe shoulder pain and dysfunction is step one. Stat Pearls provides quite an extensive list of these differential diagnoses that must be considered. It's a bit like ensuring you're diagnosing the correct root cause of a business problem before you jump to proposing a solution.
Right. What sorts of things are on that list? What else could it be?
Well, it's quite broad, as you might imagine. It certainly encompasses other traumatic injuries right around the shoulder complex. Things like dislocations of the main shoulder joint itself, which can actually occur with fractures, complicating things further, or fractures of the clavicle, the collarbone, or the scapula, the shoulder blade.
Okay.
But it also includes a wide range of non-bony injuries and conditions that can cause significant shoulder pain. Rotator cuff pathology. This is a big one. It includes acute tears, maybe partial or full thickness tears, caused by the same trauma that might have caused a fracture. Or it could be chronic issues like tendinitis or impingement syndromes, where the tendons are getting pinched. Degenerative conditions, things like pre-existing or developing glenohumeral arthritis, just wear and tear of the joint surface, or even a vascular necrosis, AVN, occurring independently of any recent trauma.
Right.
Capsular issues, adhesive capsulitis, that frozen shoulder again. Sometimes the onset can be relatively sudden, making it difficult to differentiate from the stiffness following a fracture initially, although the history of injury is usually different.
Okay.
Biceps, tendon problems. Things like inflammation, tendinitis, or even ruptures of the long head of the biceps tendon where it runs near the shoulder joint. Acromioclavicular, AC, joint issues. The joint at the top of the shoulder where the collarbone meets the shoulder blade. Things like AC joint separation from a fall, or just arthritis in that joint.
Right.
Shoulder instability. Patients might have recurrent dislocations or just a general feeling of looseness called multidirectional instability. And then, less common, but still possible, are neurovascular issues presenting primarily as pain. Things like nerve entrapments, perhaps suprascapular neuropathy affecting the rotator cuff muscles, or thoracic outlet syndrome affecting nerves and vessels as they leave the neck. Or, very rarely, vascular events like subclavian artery thrombosis.
So quite a significant overlap in potential symptoms then, really requiring a systematic approach to diagnosis using the patient's history, the physical exam findings, and then targeted imaging to confirm.
Precisely. A thorough evaluation is absolutely essential to pinpoint the exact nature of the injury or the condition causing the symptoms.
Yeah.
This is why self-diagnosis for severe shoulder pain is really risky, and getting an expert clinical assessment is paramount. And as Stat Pearls notes, optimal management requires more than just understanding the injury itself. It requires tailoring the treatment plan very carefully to the individual patient, considering their age, their functional status, their hand dominance, their overall health, and any other medical problems, even their social situation and support network, and crucially, their personal goals and expectations for recovery. It has to be a holistic assessment, not just focusing narrowly on the broken bone.
This comprehensive approach to managing these injuries, especially when you consider how common they are in our aging population, feels like it must pose a significant challenge for healthcare systems more broadly. Are the sources touching upon how the system is grappling with this, particularly perhaps the cost aspect?
They are, yes. And this is a point with significant implications that go beyond just this specific injury. The Stat Pearls source in particular highlights that proximal humerus fractures, precisely because they are common, and the treatment, especially surgical treatment and rehab, can be costly, are increasingly becoming a focus of healthcare cost containment strategies and alternative payment models.
Cost containment and alternative payment models. What does that actually mean in practice?
Well, it means that healthcare systems and the organizations that pay for care, like insurers or government bodies, are actively looking for ways to manage the total costs associated with treating these injuries more efficiently and predictably.
Right.
This includes initiatives like bundled payments, where a single predetermined payment is made to cover all the services related to a specific episode of care, say, from the initial fracture diagnosis right through several months of recovery and rehabilitation, rather than paying for each individual doctor visit, x-ray, surgery, therapy sessions separately.
Ah, I see.
The idea is this encourages hospitals and all the providers involved to coordinate care more effectively, reduce unnecessary variations, and control the overall cost of that episode. There's also a growing emphasis on standardizing diagnosis, treatment, and rehabilitation pathways based on the best available evidence and outcomes data.
Standardizing care pathways. Does that risk creating a sort of one-size-fits-all approach, given how much variability there seems to be in these fractures and, as you said, in the patients themselves?
That's exactly the tension, isn't it?
Yeah.
And STAT Pearls explicitly cautions against adopting a rigid, one-size-fits-all strategy. The goal, ideally, is not to eliminate individualized care based on clinical judgment and patient needs,
Okay.
but rather it's about using big data, aggregating information from large patient populations, analyzing outcomes from different treatments in different groups through research studies to identify best practices, understand risk factors better, and determine which treatments tend to be most effective and cost-effective for different patient profiles and fracture types.
Right.
This population-level knowledge should then inform what they call customized application at the level of the hospital or clinic and ultimately at the individual patient level.
So using the big picture data to help refine individual treatment decisions, rather than dictating them rigidly from the top down.
Exactly. It's about establishing evidence-based guidelines and protocols that can guide decision-making and reduce unwarranted variation, while still allowing clinicians the flexibility to exercise their judgment and incorporate patient preferences. But achieving this effectively requires really strong, active communication and collaboration among the entire healthcare team.
The whole team.
Yes, the orthopedic surgeons, the anesthetists, nurses, physical therapists, occupational therapists, perhaps geriatricians for older patients, social workers, case managers. Everyone involved needs to work together to ensure the patient receives coordinated, efficient, and effective care right from the moment of injury through their long-term recovery. It's a systemic challenge that really requires a team-based solution.
And just going back to those low-energy fractures in older patients, StatPros also notes that the fracture itself is effectively a diagnosis of compromised bone density, doesn't it?
Yes, that's a crucial point highlighted in the Pearls section of that source. For any older adult who sustains a proximal humerus fracture from a simple fall or minimal trauma, assessing and addressing their underlying bone health, specifically looking for osteoporosis, is really non-negotiable. Because that fracture acts as a sentinel event. It's a major warning sign, indicating that the patient is at significantly high risk for suffering other fragility fractures in the future, particularly devastating ones like hip fractures or vertebral fractures in the spine or wrist fractures.
Right.
So ensuring these patients receive appropriate follow-up, which usually involves bone density testing, like a DEXA scan, and then management, which might include lifestyle advice, calcium and vitamin D supplementation, and potentially specific osteoporosis medications. That's a key part of providing comprehensive care. It's not just about fixing the immediate break.
That connects back really powerfully to prevention then, doesn't it? If poor bone quality and falls are the major factors driving the most common type of proximal humerus fracture, then surely addressing those upstream issues has to be critical.
Absolutely. And Unknown 19 provides some specific prevention strategies that resonate broadly with the idea of risk management. For older adults, fall prevention is paramount.
What does that involve?
It involves several things. Identifying and modifying potential environmental hazards in their home, things like securing loose rugs, improving lighting, installing grab bars or handrails in bathrooms and on stairs. It also involves reviewing their medications, as some can cause dizziness or unsteadiness. Ensuring they have appropriate, well-fitting footwear is important too. And crucially, incorporating regular balance and strength training exercises into their routine can significantly reduce fall risk.
Okay.
For athletes or perhaps people involved in high-impact activities or contact sports, using appropriate protective gear like shoulder pads where relevant is key. And for everyone, really, particularly as we age, focusing on overall bone health is vital. That means ensuring adequate dietary intake or supplementation of calcium and vitamin D, avoiding smoking, limiting alcohol intake, and engaging in regular weight-bearing physical activity, things like walking, jogging, dancing, stair climbing, which help stimulate bone density and also maintain muscle strength, which further supports balance and reduces fall risk.
This entire journey we've discussed from, really understanding the intricate anatomy of the break and classifying its severity to then navigating those complex treatment decisions with all their inherent risks and trade-offs, and then committing to what sounds like an often arduous road of recovery while managing potential complications, it truly does mirror challenges we often face in many professional domains, doesn't it?
It really does. That need to deeply understand a complex system before intervening. The need to classify problems effectively to help guide action, the need to weigh different potential solutions based on evidence, but also considering the specific context and the individual system you're dealing with, the need to anticipate and manage inherent risks, and ultimately the need to embrace a resilient, often team-based approach to achieve the desired outcome. Whether you're talking about healthcare, engineering, finance, or business strategy, these core principles seem remarkably consistent.
Well, we hope this deep dive has given you a much clearer picture of proximal humerus fractures, perhaps revealing some of the layers of complexity beneath what might initially seem like just a straightforward broken bone.
Yes. From the subtle yet critical points of anatomy, the distinct patterns of injury depending on age and mechanism, the classification systems that help structure our decision-making around displacement, the important nuances and trade-offs between non-operative care and the various operative strategies, right through to the demanding but absolutely vital process of rehabilitation. And being aware of the potential hurdles of complications, understanding these different facets, really provides a robust framework for thinking about this injury.
And it all stems directly from the comprehensive source material we've been exploring today, the Orthopedic Trauma Association guidelines, those detailed reviews and stat pearls and ortho bullets, insights from the Bone School, and the Stanford AVA Lab summary document. So our thanks to the experts and authors behind all of those valuable resources.
Indeed. They provide the foundational knowledge that's absolutely necessary to navigate what is often a very complex clinical challenge.
If you found this deep dive insightful, perhaps because it helped you understand complexity through a slightly different lens today, please do consider leaving us a rating and maybe sharing it with someone in your network who you think might also benefit.
And finally, perhaps consider this provocative thought, building on that increasing prevalence of these injuries, especially in older adults. Given the clear intersection of an aging global population, the rising incidence of osteoporosis, and the significant functional implications and healthcare costs associated with proximal humerus fractures, is the healthcare system currently doing enough to shift its focus from primarily treating these injuries after they happen to more effectively preventing them on a true population scale? What systemic changes might be needed to really manage this growing fragility fracture epidemic proactively rather than reactively?
A question with some very broad implications indeed, something to think about. Until next time on The Deep Dive.